Good morning, everybody. Today I'm going to talk about otosclerosis and hearing loss, along with functional aphonia. Otosclerosis, or hardening of the ear, results from the formation of an abnormal spongy bone, like bone growth along the stapes in the middle ear. While the new bone growth, the stapes becomes immobile, prevents transmission as sound vibration into the ear, leading to conductive hearing loss. Otosclerosis usually affects both the ears. This is a picture of, you can see the tympanic membrane, the external auditory canal. You have the malleus here along with the incus and the stapes. And this is the sclerosis that has happened along the footplate of stapes, which is preventing its transmission of sound. Now, classification, there are mainly two types of classification of otosclerosis, which is histological otosclerosis and clinical otosclerosis. In histological otosclerosis, it's a type of otosclerosis does not produce any symptoms during life, but it is usually revealed only at post-mortem. That is when a person dies. If you evaluate his ear, or if you just check, if you take a biopsy of the ear and just check what is there, then you will get that he has had a history of otosclerosis. And then we have clinical otosclerosis. Now, clinical otosclerosis are three subtypes. Basically, stapedial otosclerosis, cochlear otosclerosis, and mixed otosclerosis. Stapedial otosclerosis, the otosclerosis focus may produce ankylosis of the membranous labyrinth. Whereas in cochlear otosclerosis, the otosclerotic process encroaches upon the membranous labyrinth, producing a sensory neural type of deafness. In mixed otosclerosis, the otosclerosis causes both fixation of the stapes as well as an involvement of the labyrinth, so that there are mixed type of hearing loss. Now, causes for otosclerosis, basically it is genetic factors. Any viral infection can induce measles or any other ear conditions. In clinical manifestations, basically patient will have hearing loss, they'll have dizziness, some will have tinnitus, which is roaring type, then buzzing in the ear, vertigo sensation. Some people have headache and earache also. Coming to the diagnostic evaluation of otosclerosis, first we will a detailed history has to be taken. Patient's history, like the patient will tell that he has got decreased hearing, and is not able to hear, and there is especially loud environment or not. And once we know that history, that patient is not able to hear and we have ruled, then we can look into a physical examination where we do an detailed ENT examination, and then we can look into the tuning fork test, and audiometry can be done. In tuning fork test, we will get conductive type of hearing loss, and hence it will differentiate it from the sensory neural compartment. Then we can get an audiometry. When you do an audiometry, you can get a better picture of mm, AS type of curve in impedance, which will indicate that it is otosclerosis. And on Puton audiometry, we will get a dip at 2000 hertz, which is called as Cahart's notch. And other tympanocentesis, CT scanning, MRI is not usually indicated. Audiography is the main thing that has to be done. Coming to management, otosclerosis may slowly get worse. The condition may not require treatment until you have severe hearing problems. Medications such as fluoride, calcium, and vitamin D may help slow the hearing loss, but the benefits have not yet been proved. And there is no known medical treatment that exists for this type of deafness. Especially, we can use hearing aid may be helpful. Sometimes, if the patient is having pain, we can administer analgesics such as ibuprofen, oxycodone, or acetaminophen. Hearing aid may be used to treat the hearing loss. Now, coming to the general measures that has to be taken, one is you can avoidance of noiseful environment, side lying position, continuous application of medications, and a high protein diet can help. Coming to surgical management, basically the treatment for otosclerosis is surgery. We do a stapedectomy or a stapedotomy. In stapedectomy, then the removal of the portion of the sclerotic stapes footplate and complete removal of the stapes and the implant with prosthesis have to be placed. In this, that is why it's called stapedectomy, where a segment of the stapes is removed. Whereas we do stapedotomy. In stapedotomy, it's a modern type of surgery where uh, we do a drilling, a hole, small hole is drilled into the stapes footplate, and then using a micro drill or a laser, and then we insert a piston. This piston will help, like a process is placed. The piston will help in conduction of the sound. So this is about otosclerosis. Now we'll be talking about a functional aphonia. Functional aphonia. See, before we talk about functional aphonia, we will be talking about vocalization. Some definitions like vocalization means you're producing a sound, and preferably at an emotional level. Whereas phonation is sound production with the aim of communicating by speech or singing. So the difference in phonation and vocalization. The voice production involves interaction between the respiratory system, the larynx, the vocal tract, the articulatory organs, and the cerebral coordination. Now, components of the phonatory apparatus. Um, the different phonatory apparatus are the activators, that is the power source. The power source of phonation comes from the lungs and the respiratory muscles, which provide the required energy. Then there's a generator, the generator of a voice, that is in the vocal cords. Then we have a resonator of the vocal tract, like supraglottic and the pharyngeal passes, which will resonate the voice, which will give it a typical resonance. And then there's an articulator like a palate, a tongue, the lips, and the teeth, which will articulate and result in formation of sound. The coordination of phonation originates in two centers in the brain, the limbic system and the primary motor cortex. If you look at this picture, we're talking about, see, this is the lips, the tongue, and the palate and the teeth. These are the vocal folds. This is the larynx, which has the vocal fold. This is the esophagus, and this is the esophagus. This is the trachea. So the air from the lungs comes, which is the activator. Then the generator is in the here. Then the generator is at the level of larynx. Then the resonation happens around the in the supraglottic structures. Then the articulation which happens in the mouth, heart, palate, teeth. And these are the vocal folds. See, this vocal folds are depicted here. These are, see, when we swallow, it closes so that the food which comes, this is closed, so that the food which comes, it has to go through the esophagus. And this is the place where the air enters, so it is closed. So now air causes vocal, when you breathe in or breathe out, because of the air, it opens up. And these vocal folds vibrate, when we talk. And then and when we breathe quietly, this it has to be fully open. These are the different parts of the larynx. That is, this is the epiglottis, This is the tracheal cartilage. This is the cuneiform cartilage. This is the thyroid cartilage. This is the corniculate cartilage, the small thing. The arytenoid cartilage, the cricoid cartilage. Now, in functional aphonia, it's also called as hysterical aphonia. It's a functional disorder usually seen in emotionally labile young females. In sudden onset aphonia, not associated with any other laryngeal symptom. Patient is usually able to whisper. See, we have seen many times, in our OPD, we get patients who are like this young child, young female child, who suddenly develop this hysterical aphonia, where the child is not able to speak. Maybe she might just whisper, and then mother is worried, father is worried. They say that everything is normal, but suddenly the child is not able to speak. And when we do a laryngeal examination, everything looks normal, everything is fine. But then we should be very careful when dealing with such child, because it's important to ask them history. Usually what happens is they are basically undergoing some other, maybe they're undergoing some stress in life. Mostly it could be regarding friends or something, like they may be being molested by somebody, or something else is happening, and then the child will be really in a shock and in an emotional shock. That is why they can usually present. So it's very important to deal with such case very kindly, and a detailed explanation, a detailed history taking has to be done, and child has to be comforted and spoken, and the real history has to be taken out. Then vocal cords, you see, they are seen in abducted position and fail to adduct on phonation. So adduction of vocal cords can be seen on coughing, indicating normal adductor function. So basically, it's an abductor, means it's wide open, that it's not able to close. But you see, normally it's able to close when she's coughing or having some other thing. So it's important to diagnose. But sound of the cough is also good, that which indicates that there is no as such vocal cord pathology. And treatment is given is to reassure the patient, should make them feel comfortable, and normal laryngeal function, and a little bit of psychotherapy will help. It's important to address their main issue which is associated with this. That's all for the topic. Thank you so much.